Professor, Department of Pediatrician Neonatology, SMS Medical College, and NICU in charge of JK Lone Hospital. So, sir, please come and proceed the forms.
For this session, I invite Dr. Rajesh Mathuria, sir, Dr. Dinesh Dalmia, sir, Rakesh Khandalwal, sir, Dr. Swarnkar Saab from the Pali, Dr. Satya Nemradani, sir, please. Come on, guys. Now I'll invite Vivek, sir, for their. Please. Now we are about to have a talk by Dr. Vivek, sir. He is consultant pediatric neurologist at Santokba Durlabji Hospital, Jaipur. He did his PG from PGI Chandigarh and is presently working in our city. Dr. Vivek, sir.
One more point I want to tell about Dr. Vivek. He has an extraordinary ability to represent a very complicated topic into a simple and organized way. Please, Dr. Vivek Jain.
Thank you, Rajesh. I'll try to keep up to it. Heavy responsibility. Can I have a collar mic? Collar mic. Collar mic, chi. I will control it from here. Okay. Can you all hear me? Yes? Okay. So, thank you. Thank you to the organizing team for giving me the opportunity to come here and talk to you. It's a very interesting topic Mahendra has given me. The old, the new, and the useless, right? So, I'm well aware that I'm in a conference where there are a lot of neonatologists. A pediatric neurologist in a neonatal conference is surreal. Why? Because neonatologists talk from the brain. They talk about evidence, So they're very objective. So that's neonatologist. A pediatric neurologist, he talks from the heart. So they just babble around from their own experience and sometimes use the evidence. It has been very difficult for me to keep a middle path. I hope I have done it some justice, but we'll see at the end. So let's go through a few cases, common cases. Case number 1, 3-day-old baby, very common situation. Delayed cry at birth, resuscitated, seizures from 12 hours of life. The question you always ask, phenobarbital or levetiracetam? Phenobarbital काम नहीं किया तो levetiracetam या phenytoin? That's the very common question, right? That's one. Okay. Same child, good response to phenobarbital. See left focal seizures and had a stroke in the right brain. So is the third situation. So remember, a newborn with focal seizures is always perinatal stroke unless proven otherwise. So they don't present with hemiparesis. Never. They present with focal seizures. So again, old etiology we always need to remember. So what are the old etiologies? So they are the acute reactive seizures due to HIE, due to hypoglycemia, due to stroke, due to meningitis, due to bleed. So what are the new? New as they were always old, but we have got the investigations, so now we know they are new. So we label them as new. So case scenario, you remember that baby? The second baby who had seizures from 6 hours of life, no response to phenobarb. Hypocalcemia didn't work either. Responded to pyridoxine. So remember pyridoxine, if there is no asphyxia, if the seizures don't respond to phenobarb, the second medicine should be pyridoxine. We don't do that. And any child less than 2 years age with refractory seizures, pyridoxine, if neuroimaging is normal. If the problem I see, children with hypoglycemia, asphyxia being given pyridoxine, it's waste of time. If the MRI is normal, there is no reason you give it. So case number 6, 6-week-old baby, no asphyxia, focal seizures, tonic seizures, increasing seizures. So this is the second one which you shouldn't miss. The child was covered, so I didn't examine the first time the baby uncovered. No response to phenobarb, phenytoin, levetiracetam, pyridoxine. And then he came drowsy. Is there anything you can see? Is there something different? The baby? It was a miracle. Miracle. This baby, after 7 months, what could I have given? Biotin. So biotinidase deficient. So they don't present at 2 weeks with hair loss. By 3-4 weeks they get it. So they're coming at 2 weeks, pyridoxine doesn't work, try biotin. Right? So old case causes but new because we are more aware. So term baby, day 3, seizures treated again as hypoglycemia, hypocalcemia which doesn't stop it obviously in the first 7 days. Phenobarb, levetiracetam, phenytoin, valproate, pyridoxine, biotin given, no effect. They come to me at 4-month age, right? Normal MRI brain. CSF had been done on day 6, the child was treated meningitis. So 5 cells, 80 proteins, and why did I repeat the CSF again at 4 months? Any guesses? Why would I repeat it? Nobody will agree, no parent agrees for a CSF again. Is it a normal CSF? So sugar is less, 16/80. So it's less than 40%. Cells are normal, protein is normal for the baby, it is glucose transporter defect. So this is a condition we miss, where we keep treating the child with as meningitis because of the low sugar, but the baby doesn't get fever, CRP is negative, and it's a glucose transporter defect where glucose doesn't go to the brain. So we need to give the baby, no medicine will work. Ketogenic diet, we have got ketogenic dietitian, we have had few cases and that works wonderfully. So fat has to be sent to the brain. So I'm not saying you should start it, but if a child comes recurrent seizures, don't just be, dogmatic about just looking at the cells. Look at the sugar. If the sugar is low, start thinking, is it a genetic disorder? Is it glucose transporter defect? So remember glucose transporter defect, if persistently low CSF sugar with normal sense in refractory neonatal seizures, very important. We are missing the cases. Another child, same history, 3 days seizure, multiple seizures, refractory to medicine. There are cystic changes in the MRI, and this MRI, this is the gray matter, this is the white matter, ventricle looks prominent, looks like a PVL, periventricular leukomalacia, but the baby was good weight, so no IUGR, no concerns at birth, not XPREM, term baby, and PVL babies don't present with seizures. XPREM baby present with spastic diplegia, they don't present with seizures. But this baby had just seizures, and the baby had a very low uric acid. So this is the one condition we are missing. Molybdenum cofactor deficiency is again a genetic disorder. You might think it's hi-fi, but it's not, it's common. So any child who doesn't have history of asphyxia, who has a MRI of HIE, and who has got periventricular leukomalacia, do a uric acid. If it is very low, low means it should be less than 3. So normally it is 0.5 to 1. 3 and above is normal. So high uric acid nahi dekhna, isme low dekhna hai. Right? Now this one. Right focal seizure newborn, we talked about another baby who had focal seizure, who had stroke. But this baby didn't have stroke. So this baby, so did you see the seizures? Just now the baby stiffened. So, looking to the right side. So the child is in seizure. Yeah, here it comes, right? So this baby had hemimegalencephaly. The left side of the brain was abnormal. Right is normal, left is abnormal. On MRI, left is on the right side. So left is abnormal. EEG shows continuous discharges. So 3-day-old baby, hemimegalencephaly. So if the baby has focal seizure, if it is not stroke, look for a cortical dysplasia. Right? Okay, so what is the new? So if a baby is encephalopathic, we look for metabolic disorders. MSUD, non-ketotic hyper, HIE, MRI, think of molybdenum cofactor deficient. No encephalopathy, seizures, give pyridoxine, give biotin. If it is focal seizure, think of cortical malformation. Don't forget GLUT1. If you are doing CSF, think of low glucose. And then genetic testing, obviously, later, which we can do. So, and what is the useless? This one you have to answer. So, baby, always in sleep, never on face. What is the diagnosis? So, sleep myoclonus. This is useless. You know, you don't need to do. One of my colleagues, baby had this in PGI, and that was the VIP syndrome, and we gave her midazolam infusion, we gave her phenobarb, and more do you sedate them, more it increases. So never on face. Remember this, never on face. So, okay, you know about the sleep, but never on face. Okay. So, neonatal seizures causes acquired, the most common, hypoxia, hypoglycemia, infection, stroke, genetic, less common, metabolic disorders, structural. What is useless? And you will say, hypocalcemia kaise useless lik diya? I give hypocalcemia as the first diagnosis if a child comes after 2 weeks. अगर मेरे पास बच्चा 1 महीने पे आ रहा है, तो मैं कहूँगा इसके विटामिन डी डेफिशिएंसी देखना है, कैल्शियम लो देखना ही है. पर फर्स्ट 7 days में आ रहा है, तो I don't give a damn to it, you know, because कैल्शियम लो is a physiological phenomena. न्यूबॉर्न का फर्स्ट 5 days में कैल्शियम लो होता ही है थोड़ा, और हम उसके behind हाइड कर जाता है. Early onset hypocalcemia doesn't usually cause seizures. It is something else. एंड हम उसको पेरेंट्स को सेटिस्फाई करके कैल्शियम बैठ देते हैं, वो वापस आता ही ज़्यादातर. आई एम नॉट सेइंग इट इज ऑलवेज, बट आफ्टर 2 weeks, यस, फर्स्ट डायग्नोसिस विटामिन डी डेफिशिएंसी रिलेटेड हाइपोकैल्सीमिया. ओके, सो हाउ डू यू इन्वेस्टिगेट? So old investigation, we do blood sugar, we do CPK. Why? Because often we don't have a history of HI, because sometimes it is hidden because of the medico-legal issues, and child comes to you at 2 days with seizure. CPK is high in HI. Urea creatinine, renal dysfunction, CSF infection obviously, but always look at the glucose and plasma glucose ratio, and MRI to help sometimes to diagnose. What are the new? So ammonia, metabolic में lactate, blood test, uric acid, CSF to plasma glucose, glycine, biotinidase, TMS, and genetic testing. We neurologists can do it, but we should think of it. So new causes, right? I'm not going to talk about amplitude EEG because that's beyond the domain. That's more. There's a separate talk one can do on amplitude EEG. And what are the useless investigations? Attributing neonatal seizures to early blood pyridoxine levels. So often I see blood B6 level normal क्या होता? The pyridoxine dependent epilepsy is an intracellular pyridoxine defect. So blood pyridoxine is normal. जो भी lab कर रही है वो भी गलत. We should not do it. And neonatal EEG in our country, it's a useless test for my country because majority of normal EEGs are reported abnormal. They are done on poor quality Indian machines and they are reported by technicians. 90% of EEG जो मेरे पास neonatal आते हैं सारे normal होते हैं, सारे abnormal report. You are putting your foot in your mouth if you are doing a neonatal EEG. Don't do it. Go clinically because वो resources नहीं है. So first 2 weeks seizures, just a flow diagram, multifocal, focal है तो MRI, stroke, malformation, multifocal है तो history of asphyxia, classically 12 to 48 hour seizures, renal dysfunction, hypoglycemia, later seizures, 1 to 5 days, right? And infection है तो CSF, and if that is not there all, give pyridoxine and start testing for ammonia, blood sugar, TMS, and CSF plasma to blood glucose, genetic, and all that. So what about treating? Because that's the most important. A 2-day-old baby, delayed cry, resuscitated from 6 hours, and seizures from 6 hours. You know, typical. Which drug? That's the first thing. Phenobarbital, phenytoin, levetiracetam. So old is gold, right? Phenobarb. Much maligned. We have phenytoin. Does it work as good as phenobarb? So there's only one study in 1999 in NEGM which compares phenobarb to phenytoin, randomized trial, and the efficacy was 55% for both. But the problem with phenytoin, we have lost 2 children because of cardiac arrest. Fosulin is there, but phenytoin problems, the more important point is extravasation. It causes bad extravasation. And the levels are never maintained when you discharge. I have done so many